So let's get started. I have a question, Dr. O'Rourke. It's difficult when students come into nursing programs. Many of them don't have any experience whatsoever. And as I said earlier, we teach them a lot of tasks and they focus on a lot of tasks. How do we instill or begin to instill professional identity in very beginning nursing students?
Thanks, Donna. Do it. First course, that's what we're doing at St. Mary's. Embed it in every single program, every single course, every single class. Educate your faculty on how to sing the song. Make sure that the song is sung as soon as they open the program. This is what professionalism is. This is what professional nursing is. Now let's talk within that framework. It has to be integrated and clear and articulated. It does not come from osmosis. There's also literature. There is no kind of book, but there are excellent articles that can be put together. We used to call them, when you used to take a bunch of articles and put them it's a collection of articles. So you can construct a collection of articles that speaks to that. And then their responsibility is read and then not just read, but to read and come back and have a dialogue. So again, it has to be around dialogue.
Thank you. Dr. Luce, in learning how to listen, it's an art rather than something that we're all born with. Can you talk a little bit about the aspect of communication that is left up to interpretation rather than maybe what somebody is trying to convey? And so what I'm thinking of is if I have a student who I think I'm communicating clear as a bell, but their interpretation of what I'm saying is not what I'm trying to say. So is there a feedback loop that must be done when you really want to communicate clearly?
Am I on? Yeah, there we go. I'm glad you asked that. I was going to talk about it. So it's all comes down to perception, right? The perception of the hearer, of whether you're listening or not. So that's why I used as my theorist for my doctoral work, I used Imogene King because she focuses, her model looks at a shared goal, reaching a shared goal, but she starts with perception. And so if the perception isn't there, then all of the rest of it doesn't happen, or if it's a wrong perception. So part of it is you have to come with what is the goal that we're trying to reach. That's how you start the conversation. And if, the things that we do all the time now is, rephrase, reframe, say it back, paraphrase, whatever. You still have to do that to understand, am I getting to what you're wanting me to get to? Do I understand? Am I getting this right? And they're always happy to clarify yes or no. They don't hesitate from doing that. So if to get to a goal that wasn't there, they will a lot of times just go along for the ride because they see a power position and they see you taking the lead and off you go. And so if they see you doing that without you stopping to validate that this is where they want to go, they're not going to say anything. So the validation process throughout. Does that make sense?
Yes, thank you for that. And so one of the things that we try and do with students is we try and make sure, did I explain myself? Do you have any questions? What did you hear me say? And that's especially helpful once you can calm a student down and get them to think and talk to you. Because sometimes with students, it's a matter of perception. And so that goes to my next question, Dr. Clark. What role does perception and interpretation play in dealing with incivility?
It's huge. Am I mic'd? Okay, so I love this question. Let me just say that one of my research teams and I just recently published a concept analysis. We revisited the concept of civility and published that in Nursing Outlook in 2022. The original concept analysis we published in 2008. And it's like, what has happened over time as we define civility and what it means? One of the things that's very consistent, and the model we developed showed this big arrow that we labeled perception going through all of the antecedents, the defining attributes, all of that. So perception is everything. Perception is everything. And so understanding where one is coming from, I believe, is integral, and listening is certainly a part of that. I also think that it's super important that we have frameworks to structure the conversations we intend to have with people. And there are lots of different evidence-based practices. I would just ask for a show of hands, how many have heard of team steps and the CUS model and the desk model? Well, there's a whole lot of other models that built listening into it. So to understand other people's perceptions.
Thank you, Dr. Clark. I need to stand over here. Dr. Stanley, in all of the things that you have achieved in the programs that you have implemented and sustained, what has been the greatest challenge?
Faculty. I think we all make assumptions. And so I'm not sure why I made the assumption, but I just assumed, like a lot of people, you hire faculty in, they were great as nurses. They're going to, they've taught patients, that there would be some bit of transfer in those skill sets. So the first gap is not all of our nurses that come over to teach are really prepared to teach students. It's a different teaching. So that's the first piece. The second piece, I'm still to this day always surprised. I keep saying I'm going to stop being surprised at the number of people that haven't read their practice act. So when you have nursing faculty that are coming in to teach, and now they don't really know how to teach and to transfer the knowledge, they can get up there and preach, but there's nothing that's necessarily exchanging, and they don't know the practice act, they don't know the ANA standards, they don't know the code of ethics. There's a lot of training of everyone. So in my first go around or second go around at this, I didn't really have all the stuff in place for the faculty, so it was a lot of catch up. So this time, even the faculty, it's all my faculty that followed me, but I'm really hardwiring it. So we're having a training session Tuesday where we're going over what we've agreed as our pedagogy, what we agree we're holding each other accountable to. So establishing, and I know I'm very fortunate because I'm establishing a culture and not changing a culture. But you have to have the faculty in place to really support and mentor the students. And unfortunately, it only takes one rogue faculty to really spoil it.
Hello? Oh, there we go. I would just add to a recent example that really underscores Pam's comments. I was on a conference call with key educators, heads of schools, and one of the individuals on the call had brokered the conversation, and she was quite upset. And so she said, I have to say this. She said, I was just on another phone call, because she'd come from another phone call to our phone call. And she said, I cannot believe I heard this. She said, there was a PhD prepared faculty member for when we were talking about courses and curriculum, said that the scope of practice was optional. Not optional in the curriculum, optional. So if we have that level of disinformation, we need to change that. And everybody in this room can change that. Your legal scope of practice is the legal nursing codification of a professional model. It's a double for us. I mean, some people don't have to have a license to tell them that they're powerful professionals. we have not only the sociology behind it and the articulation of the tenets of a profession, we have a scope of practice. We got 3. So it's rampant. And we have to turn that. That is, first of all, it's disinformation, and it's going to get somebody hurt. Thank you.
Thank you. Questions from the audience? Or my friend would say, who has the first question? They don't give you an option to not have a question. Ma'am.
Thank you, ma'am. And I just want to tell you that personally, from Dr. Hedges, she's been great. She is a very humble leader. And to me, seeing a servant leader is huge. So I just wanted to give a shout out, ma'am. So no, but I do have a question. With that being said, I do have a question. Any suggestions on, I get it. We all need to make money. Every place, every school, every, hospital, we need to make money. Everybody likes to get paid. What would you suggest if, there's certain things, certain expectations, and I'm coming from a faculty perception, if you have, expectations for teaching so many hours, whatever, if you're full-time, adjunct, whatever, how do you pay for time for people to reflect? I don't think we do a lot of reflection in nursing. That's just me personally, is like do the task, do what you need to do. And how would you suggest that we, pay for this to encourage our academic places to say it's worth it to have the training and the those kind of things for our staff? How do we pay for it?
Again, a luxury of being new. I've actually built into the, for lack of a better word, the FTEs, they call them workload units, that all the faculty are getting 2 workload units that are full-time, that are the expectations for them to come to meetings, whether they're content expert or whatnot. Those will provide, as you're talking about, the reflection, the building, the collaboration. So it is compensated. For those that are doctorally prepared, which is a smaller group, we are actually going to be giving them an additional 4 units to produce scholarly research and stuff like that. That, I have to say, is part of the culture of the college I'm in. So it's kind of helpful if the college already values that. So I only had to advocate for the non-full-time doctoral degrees for those 2 units. And then for adjuncts, we will appropriately add units for training and whatnot to their courses. The other thing I was able to do, because this is an opinion, I have no proof of this yet, just an opinion. Clinical faculty can sometimes be a bigger challenge because they rotate through. And so we're actually paying them an additional unit for that clinical experience. And part of that unit is so that they actually have to onboard each semester with their students. So every semester when they come, they don't just go out to clinical, they have to onboard and they come to the simulation center with their students, and they have to get checked off as a group that the group is prepared to be practice ready to go into the clinical environment. So do they know what's in the syllabus? They all agree what the rules are. They all understand what the students can and can't do. They've all worked as a team in providing care, and all of that is done in an 8 to 10 hour day, and that's all been built in. So that allows also reflection time, because once we've done that with the faculty and the students, we then meet with the faculty to do some mentoring to how did that go? There's going to be parts of it that are filmed, so she'll be able to see herself, or we can have those conversations. So it's not designed to be punitive, but it's designed so when the faculty member actually gets to the clinical site, they know how to do pre-conference, because that was an aha. They know how to do post-conference where they really can make it reflective for the student. But if we haven't done the reflection with the faculty, to your point, they can't reflect with the students.
Yeah. So having went to school at, and teach at faith-based different situations, every single one of them, we would start every meeting, every gathering and you probably have done this with some sort of reflection, some sort of quiet time. So it isn't the amount and intensity of that, but it's built into the culture there. And so we don't start anything. We don't just get into it. We have this quiet time. We have somebody deal a reflection, and it kind of sets the tone for the rest of our meeting time or class time.
From a service side, maybe not. Been there? Okay. Until we stop thinking about things as things to do, as a way, as opposed to a way to be. So I'm never not reflective. It doesn't take me any more time to be in a reflective mode than to be in a it takes me more time to be in a non-reflective mode, because when it's non-reflective, I get in trouble. I have to be in a reflective mode all the time. It's the way I am. And what we're trying to do, what we will do, not trying, you cannot try, you just do. And from the very beginning to say, it's your way of being. You're always in a reflective mode. Otherwise, you won't listen. Otherwise, you won't be able to see the context unless you're in a reflective mode, because then it's a me mode. And it's not about me. It's about my being reflective in my perception of what's happening to the context as well as the people in the context.
Thank you. Other question from the audience? I have to pick names out of a hat. Go ahead.
Learning without behavior change is irrelevant. You got
Go ahead,
I,
Robin.
woo, that's hot. That's called Benedict. That was a hot mic. Okay, I have a question, and I don't know who would like to answer it. I could direct it, but if there was an administrator in a program who felt that it wasn't necessary for BSN students to be involved in legislation, advocacy, whatever, what would you say to that person about that attitude? False? Oh, you're fired. Oh, that'd be an easy out, but
for me, this is where that unpleasant truth needs to be politely, and I would practice this, and I would have ChatGPT help me with my speech before I did it, since it's my boss. So off the cuff, I would have a conversation about what the role of the nurse is in legislation and overseeing their practice. And if our students don't understand that we are a self-governing entity, what's going to happen to the practice in the future? It would be more scripted in that way, but she's lacking role clarity from her position, and the fact is we are responsible for understanding legislation.
I would frame it from the perspective that I'm assuming you said administrator, were you talking service or education or both? Education. That the root of the funding for programs, money talks, comes from making sure that the legislation that is passed supports the ability or anything related to the development of the workforce. So you have to find a way to make it relevant. Money talks, and legislation that undoes nursing practices or workforce environment or anything related to building a healthy organization, school organization, where your funding is going to get cut because nobody's advocating for it. You want the students in your program to be out there advocating for you to get money in your school. And they cannot do that if they don't practice under your wing.
If we don't do it, someone else is going to take that mantle on and going to represent us, or going to try to represent us, and they're going to do it wrong. So having just written a report for a state's legislature, it was important to get the nurse's voice and to get it out there so that they understood from a nurse's perspective what the status of nursing is, not from an administrator's status or from an administrator's bird's eye view or somebody else's. And so without that advocacy at that level, nobody's coming to rescue us. We have to represent ourselves. And this is a core tenet of who we are and what we believe. That may not be your functional role to go be an advocate at that level, but you should, at least in my program, we had to at least learn to, who is our representative, learn to lobby, have an issue, whatever that issue was, and write it up and bring it. And that gave us at least a respect for the people that do this and an understanding that we need to be still aware of what's on the books and what's coming down the pike. And then it may tie you to your professional organization, which I would hope that it would, because each time you do that, at least in ours in California, we go every year and they have a whole session of legislative agendas. And yeah.
I have one more thought on that. I would say to that person, could you please help me understand why you wouldn't want your students to do that? You need to get in that person's head. There must be some experience or something that they're thinking about that you may be unaware of. And it may be the thing that if you addressed it once you knew it, because you don't know what you don't know, you might be able to target the discussion very specifically to that experience. But you have to ask that question.
Thank you. Yeah. Can I address the person in civil on an uncivil manner?
The administrator in
The
your
response. Can I address this person in an uncivil tone of voice?
Well, you could. I wouldn't advise
Oh,
it.
you wouldn't
but,
advise it.
I used to say to my students all the time, you may have the greatest idea in the universe. It may be world changing. However, if you cannot present that idea in such a way that it's respectful and that people can hear, the idea really falls apart. So much of my work is around how do we have those critical conversations when things are very challenging. And so I'm always of the mind that in teaching ourselves strategies, the other thing I do a lot with groups, nurses, physicians, others, is how do we interrupt that impulse that we all have in our own humanness. So to give it back or to retaliate or to act in kind. That's who we are. That's how human beings are. In fact, there's some just excellent work by some early theorists that when they were talking about workplace incivility, their subtitle was tit for tat, because it's such a common response. So for me, a lot of my work is helping people interrupt that, to put that pause there. One very helpful strategy sometimes in those situations, as you're regrouping, and maybe I'll talk about it tomorrow in a little more depth, I'm not sure where that'll go, but having silence, just sit there for a moment, or asking someone, could you say that again? If somebody says something to you that's really rude or disrespectful, could you say that again? Or something like, did you mean to have that come out? Or did you intend to have that come out in a hurtful way? Because that just hurt. Those are the kinds of conversations. So I would go with the respectful versus uncivil.
Can I ask for a point of clarification about the word using you?
Yeah.
What did you think? I always feel like that's parental, as opposed to saying, I found that disrespectful or hurtful. Can you shed, how the better approach?
Oh yeah, absolutely. So you did it well.
I did it well.
Yeah.
But again, should we use you, or should it always be how we feel, how I feel?
It sort of depends on the situation. Generally speaking, no, you want to speak in different terms, like I experienced X and it impacted me in this way. Was that the intent? For me, a lot of times you can change you or your to the intent rather than your intent. You see how some of those things sort of work, but yeah, it's not easy. It's particularly when you're in the heart of the moment, the heat of the moment. You know, when things are coming at you, how do you respond? And that takes a lot of practice. If we don't practice it, we're not going to be able to do it when that time comes.
I talk to myself in the mirror a lot.
Yeah, you know, that's one strategy. Another is to really, one of the things that I use a lot is cognitive rehearsal, which is a way of having people role play their experiences with uncivil encounters or conflicted encounters. Really, literally get on a stage, let's role play it. And then the real work gets done though in the debrief. You know, now let's debrief that. Let's deconstruct that. What was it like? What did it feel like? What did it, you know, you spoke earlier this morning. There are things that we have that happen to us as children or adolescents or whatever along our life path that gets triggered. So working through some of that.
Thank you, all of you.
Okay, all right. Who had their hand up first? Okay. Here we go.
This question actually goes back to, I think, your first question, kind of around the advocacy and being aware of the political environment. Nurses notoriously do ourselves zero favors in the sense of being aware of what's going on out there. So, Dr. O'Rourke, one of the things you mentioned was the suits. You know, they came and they started to bombard us as nurses, and they're coming back. So just out of, you know, from your perspective, each of you or whoever would like to answer, what do we as nurse leaders need to keep an eye out for? What are some of those early indicators that things like that may be coming our way? And how do we position ourselves to overcome those when we know it's coming for us?
First of all, you will be blindsided. There is no anticipation. Just know that the tenor right now is to bring in the suits. And I have a experience with a colleague who just walked in one day and they were there. That was troubling, and her ability to stand up and talk about nursing and sing the song was the only thing that helped her in that moment to stabilize her thoughts and her issues. And they were not pleasant. They were not viewed as, you know, a pleasant response. They were unpleasant to the suits, as was mine. Just, you don't know. You're going to walk in one day and there'll be a kid that's wet behind the ears out of accounting who went to nursing school, who's never practiced. They're counting the beans and doing the staffing for you. You need to be prepared for that. So know your stuff. Just know your stuff. You know what you do. You know how to do it. Hone it, and be prepared to speak clearly in a thoughtful and respectful way, and stand up for yourself. Now, that will get you in trouble in many cases. So you need to be prepared for that. It will come. I hope that helped.
I'd like to start the conversation by saying, oh, I'm so glad you brought that up because I've really thought a lot about that. And so I'd like to just express to you where we are coming from as the nurses within this work setting. And so not only our scope of practice, our practice acts, our codes of ethics, but having those in your toolbox to say, you know, that completely opposes the code of ethics, where I am bound as a nurse, obligated, required even to fill in the blank, you know, because the code's awesome, because it's got, you know, I don't know if Dr. Geiger's still here, but that's one of the things that I use a lot is the code of ethics, and extending beyond the ANA code of ethics. Tomorrow I'll mention our International Council of Nurses. This is worldwide. I don't know if that we have any Canadian colleagues in, yeah, I mean, looking at the Canadian Nurses Association, there are binding documents, statements, that absolutely require us to behave in different ways, certain
Right.
ways.
She just channeled Teresa, my colleague. And it was, what I just heard you say was literally an exact.
Oh, cool.
She
I don't-
was,
I don't
because
know.
that's how she was able to stand up in the room, is to do exactly as Cindy's saying right now. And that will help. But their goal is singular. The goal is singular, take out the money. So the question is how well you articulate may or may not have an impact on that. Now, one of the things that I think is very important for those of you who are in states that have ratios, learn the ratios well. Learn how you know that you have to abide by a legal statute that says X, Y, and Z. In California, it's very strong. And if you can stick to the facts, these are facts, but also know how to operationalize them. Give those scenarios where you can say, you know, when we don't have these boundaries and safeguards in place, we hurt people. And then start talking about the cost of what it means when somebody sues the hospital. You've got to move to the money part in this way and show how what Cindy is saying is the anchor to prevent those situations that cost the organization more money than any nursing staff will ever cost.
That will take some facility with understanding, you know, business and finance and all that stuff. Because when I was able to go into my CFO and have the picture of the ROI with and without this and be able to speak his language, it was a whole different thing. He's one of my biggest fans and we're really good friends. He's retired now, but I never got anything from our CFO before that because nursing was always just sucking up the money, you know, quote unquote. And he did not understand. And so it was important that my whole little tribe back in our alleyway there, we all learned to speak that language and it made a huge difference. And, you know, I was in charge of capital and all that stuff. And it was, you know, went to the big ticket items, but nursing, you know how much you're going to save. You don't need extra when you have the right equipment for nurses, when you keep it up, when it's not breaking all the time. These are the kinds of things that you need to be able to articulate.
Thank you. I'm going to make my way over here, but a couple of things come to mind. Has anybody ever heard of the book, The Art of War? All right, so that's like, using the term loosely, that's our Bible these days in healthcare. So the art of war, the whole premise is learn what your enemy is interested in. Learn their tactics, learn their strategies, and be able to answer them, and don't fall into being overcome by your enemy's strategies. The second thing that comes to mind with communication, with civility, with the things that we've just been through, integrity is not a part-time activity. Integrity means that we either have it or we don't. So whether we're communicating or whether I'm a dean, you're a chief nursing officer, you're a director, it's a full-time job. And these days, and it's going to get worse, to your question, is we really have to double down even harder and be able to have the data at our school. You just don't go in and go, you know, I think this is a really great idea. They want to see the data. So go in with data. But at the end of the day, if that's not the place for you to be because it smacks up against your values and what you feel is inside you as your integrity, it's time to go somewhere else. Sir.
Matt, so, and it's coming back to your question. I'm sorry, I don't know your name, but what's your name? Tuesday? That's an awesome name. That's a great name. I'm all about names. It's so much of who we are. It's our identity. So hi, Tuesday. The other thing I was thinking about is how formidable it is that we are not isolating into our nursing silo, and that we are an interprofessional team of people, health workers throughout the entire organization, and having a group, or a collection of professions, where wouldn't it be awesome if you're fighting for nursing and you have a physician colleague who says, you know what, we absolutely need this, and here's why. Here's how nursing augments my practice. Respiratory therapy, look, through COVID in particular, if we hadn't worked together, the casualties would have been even greater. So I'm not about siloing at all. I'm much more about how do we extend our influence among all of the health professions within our organizations. And if we're in an academic institution, well, one of the things I see that faculty in nursing do that I find troublesome is, I'm so busy I can't be on faculty senate. I'm so busy I can't be on committees throughout the university. I'm so busy. And it's like, gosh, that's what's going to save us, is, to be, because in colleges and universities, nursing faculty is often seen as elitist. Why is it that they think they need to have the resources they're demanding? Do they think that we don't need those as well? So I'm all about, how do we include all of the disciplines, whether we're in an academic institution, a health institution, a legislative institution, policy making, whatever it is. We need to work together. We can't do it alone.
So as someone that came into nursing from a different profession, because I was a computer engineer for almost 20 years before I came into nursing, I do see things differently a lot. So I get into some kind of discussion with people. We talk back and forth because I see things from a different perspective than most people that have been tenured in nursing. And looking back to when I was growing up, I know that I had some opinions. I know I had a way of thinking that when you compare it to how older people think, it's never compatible. And the older people will tell us, oh, you're too young, you don't know it. When you get older, you'll see it differently. But we moved with that. And we still we refined it, but we moved with it. And the new generation came around now. They are seeing things differently. So my experience with students now is, if you think you would teach them the way you taught people 30 years ago, you're wasting your time. They're not listening. They don't like reading books. They don't like, there's so many things. So now my question to you is this: as nurse leaders, and thank you for getting us to where we are, because I know I'm a beneficiary of all the work that you guys have done. But as nurse leaders and policy influencers, what are you doing to stem the tide of disconnects that students have? Because most of the things I hear from them is they do not feel very involved. They don't feel like they belong in the profession, because the policies and most people, at the top echelon of the profession, they're not speaking to them. So a lot of them fall out of nursing because of that, because they just don't feel themselves meshing into the whole system. And the complaint is that, the policies they make are not, it seems like it's more suited to the older generation than the new generation, who are now, taking over things. So what are you doing to integrate these new students more, these new nurses, new students, into nursing better, so that they can feel belong?
I think there's a couple different pieces in there. You're talking about both the policies and stuff that's put in regulations in hospitals and the practicing under and that. And then you're talking about the student connection. So the students coming out today, I'm only 10, but I started my career in the 80s, so you can figure that out. So I'm that older, Generation X, kind of at the older end, and now we're seeing the Generation Z generation is what we're teaching to in the millennials, and they have come from a whole different environment for learning. They think different. So we're interviewing students right now, and typical, you're to write a 3-paragraph thing about how you think AI is going to change healthcare. Then after they're done with it, we tell them, rewrite it using any AI platform you want. We're actually planning to integrate and use AI from day one in our program. And so we are going to be involving the students with how we use it, still assuring that we have the integrity and that we know you still have to do the research. One of the first assignments they're going to be doing in small groups in my class is each group is going to be given a different card with different wording to basically create a presentation around vaccines. And one of them is to work with ChatGPT and have it provide you a presentation on all the reasons you should not vaccinate your child. ChatGPT gives back out what you put in. And they're going to get all kinds of reasons that aren't evidence-based that it's going to feed back out because I already tried it. So it's teaching them how to use AI and us embracing it from the beginning. In order for us, the majority of my faculty are older. I had to get my faculty on board who thought I was crazy. They wanted to know where the drugs were. I'm like, catch my mind, we don't have drugs yet. And I actually gave them a couple hours to produce 2 to 3 policies and procedures we needed. I said, you better go use AI. And they felt they were cheating. And then once they did it and then edited it and brought it back, now I have them all using AI. They're finding AI I didn't even know exist. So in working with our new students is how do we look at where the world is now? More importantly, where it's going to be in 10 years. I don't know if anyone realizes, but the AI platform for triaging in the ER is 89% accurate. I'm a house supervisor, remember? On a given night, I'd say 50% of my staff nurses that do triage aren't 89% accurate in how to order them. So AI is coming to our field and it's going to change the world. So to your point, as far as the nursing element, it's already there. The rules and regulations, the hospitals are going to be forced to change and adapt to this new generation in the next 5 years. They're not going to have a choice because the technology is coming in ways to replace certain aspects of our work or enhance them. The real question is how do we as nurses, and this is an opinion, how do we as nurses ensure our value in the system by showing how AI enhances our production and not replaces us. And that's where I believe we need to really be focused on.
So the thing in the hospital, what we've been told by young up and coming leaders is retire. Get out of the way so I can have my shot, right? And so we have to take that to heart. You know, they need to be given opportunities early on to be in leadership, whether it's, you know, a functional leadership role or leadership within, you know, their bedside nursing or whatever. And let them run. You know, we dismiss them at our own peril because they have great ideas and they're good, they're great thinkers. You know, I do a lot of mentoring of young nursing students and nurses, and that's all that they really want is the opportunity. And what took me 5 years to do, they're doing before they even get out of nursing school, you know, getting their ACLS or doing whatever. And they're, I'm also working with young entrepreneurs. And it's like they have great ideas, and we have to A, believe that they have good ideas, B, get out of the way and let them do it and give them opportunities to lead early on.
So, so you had mentioned, you know, workload. How do you get that workload? I think I'm not on. Hello. Students need that too. You know, how can we give them credit, if you will, for learning some of these roles, for bringing their new ideas in? There's all kinds. So let's just look at the academic environment for a moment as it's structured in terms of teams and committees. We're talking about things like curriculum team, admission and progression. I'm just naming some of the common things that you would see in a nursing program. Students can sit on those committees and teams. I've done it myself. I taught leadership for 20 years at the university setting, and helping my nursing students sit on those teams and committees, learning to have excellent work sessions, bringing their ideas, generating new solutions, and then getting credit for that. So I think there are lots of different ways that we can encourage our student voices to be heard, because it's going to serve them well in the practice environment. So go ahead.
I agree, and agree. And by the way, there's no but. But is a discount statement. So, and I would add to the conversation by suggesting in the following story. So you're in the car and you're driving, and there's a stop sign ahead, and you make a decision. I'm going to stop. I'm not going to stop. I'm going to Hollywood stop. I'm going to do something else at the stop sign. The bottom line is you have to stop. And if you don't, the red light goes on and he or she follows you and says, why didn't you stop? And you say, well, I don't think I have to. Or, oh, gee, I'm a Gen Xer. I don't believe in authority. Excuse me. There are rules that we have to follow. They're not negotiable. The Practice Act is not negotiable. So when I hear or potentially hear, well, I love following doctor's orders, which is the dependent function, but all that nursing science stuff, that's not for me. That is a violation of your scope of practice, and it is not supporting the ANA standards. It is not supporting the social policy statement, and it is not supporting the code of ethics. So you have to know where to draw the line. When somebody says to me, oh, well, I only like working 2 hours a day, and so I want my schedule. And you have to say, well, wait a minute, there's another team here. So we have to look at the schedule. Well, I only work days. I said, did somebody not tell you that we're open 24 hours a day? Did somebody not tell you that the lay of the land, when you pick nursing or you pick a field in which it's a 24-hour operation, that everybody has to sort of take their turn, and that we have to have some ways of measuring some fairness? You just can't leave it to the night owls. I like to stay up at night, but you can't leave it to me all the time to be on the night shift. I think that we have to be clear that there are some things within each profession. It doesn't matter what they are. It's like a physician saying, person who's a physician saying, well, I'm a surgeon, but all those hand washing rules, I don't think I'm going to follow them today. It doesn't work that way. So we have to be realistic. I want every single student nurse to be involved as an advocate. I want them sitting on committees. I want them engaged. I want them taking leadership position, and they need to know how to sing the song. They need to know the rules of the game. And just because you happen to be born in a certain generation did not excuse you from those rules. And the police person, is not going to say, oh, well, don't worry, because you're, Gen X, I'm not going to give you a ticket. You're going to get a ticket no matter what. There are consequences to breaking foundational rules that protect public from us. And we have to remember those no matter where you are.
And I think, fundamentally, we have to understand and listen. And you can't understand if you don't listen. And when we seek to understand, we can also explain, that would be a great idea, or this might work. Here are our limitations. And if there's a situation to where you can do this much of it, you can say, I can do this much of it. The others, we have structures in place. But it's a challenge. It takes time. And it really behooves us to understand who our students are in order to be able to reach them effectively.
Oh, Dr. Hedges, actually, I have a question for you. So, first of all, I want to thank every speaker from the morning. Like, it's a really valuable suggestions that I can take it to my workplace and start helping the organization. So, I work for the long-term care setting, which is like long-term care setting, which is coded as underfunded or like a poor quality settings. So now, um, we do have clinically sounded nurses, like they're clinically sound but not professionally. So when I say low professionalism in the long-term care, it automatically refers to the like abuse. Abuse citations are very high in the long-term care setting because the low professionalism leads to the abuse, right? So now, which increases the risk for the facility, like getting more citations and all that. So now we have a nurses with the broken hearts, or I would say my facility is located in the west side of the Chicago. So let's say that I'm in the similar situation what you were explaining this morning. I do get my employee population from the west side of the Chicago, where we have a different culture setting, or like their backgrounds are different, and minding we are dealing with also mental health population as a resident population. So now how am I, or as a nurse leader or as an organization, how am I going to turn this vulnerability of the nurse to a strength to improve the care? So what kind of a training or the recommendations that you try to give? Also why I say that is that these kind of perspective what you have put in this morning wasn't there before, like social determinants of the learning was not addressed in the nursing schools. Now the research has advanced a lot in the nursing, and a lot of experts coming in and correcting the situations, but back in the days it was at the how I can say, like it was not advanced. So what are your thoughts about this?
Thank you for that question. The first thing I would say is you have a beautiful segue because you've come to a conference in which we've talked about listening, professional identity, civility, and how trauma affects people's ability to relate and to learn and do all those kinds of things. We've learned about how when the rubber meets the road, what kinds of things does that require. So if I were faced with that, the first thing I would do is education. And I would present it as, I went to this conference and they were talking about professional identity, and I wasn't really quite sure what that was all about. So, I talked to Dr. O'Rourke and looked up some of her stuff and did some thinking on my own. And we're going to have a learn at lunch about what is professionalism? What is professionalism in healthcare? Because not all your staff are nurses. So you have another aspect of including those people who don't see themselves as nurses, who aren't nurses. Our workplaces are culturally diverse. And so within your organization, if you have, let's say, 4 different cultures, I will bet you all the money I've ever spent, which is a lot, ask my husband, not everybody knows about what my culture is, what your culture is, what their culture is. Do you have a session once a month, once every other month? Tell us about the XYZ culture. What kinds of foods? What kinds of healthcare? The really slick way you can do this is in that culture, what kind of healthcare concerns do they have? What kind of healthcare expectations do they have? Are men allowed to take care of women? Who speaks for our resident? And so I always go back to education, because approaching it from that way, rather than from the way of, look, we're all doing this wrong and we're going to kill somebody someday, or we're going to get fired, and so we got to do something. Envision coming alongside people. That's what I try and do. Coming alongside. What's the need here? If you have a diverse staffing group, what kinds of things are you seeing that really need to be addressed? Are there things that really interrupt the integrity of that collaboration for the team? if there's an issue with a particular resident, heaven forbid, if, the regulatory agencies come in, that should be something that everybody comes in to the conference room and we're going to talk about this. Here's what happened. We don't do a hunt for the guilty, but let's look at where did our system fall off? And I think if we educate people more, rather than just expecting them to plod along, and even in the hospital, the nursing assistants, they're like, person non grata. They're out doing all this stuff, and sometimes nurses don't even know half the things that they're doing. But I would approach it from an education standpoint, and then valuing what's the culture. Pick a culture. You can ask somebody, do you feel comfortable doing this? Or I'll work with you. And if you focus on what are the healthcare concerns of that culture, that's really information that all of us need. So that might be the beginning of the way I would approach it. And then as you logically approach it, things are going to fall out. And then you're going to have to be able to address those things. Does that make sense? It's not easy. And it's not, there you go, there's the answer. It takes time. But if we draw people in and give them a stake in, why do I have to know this? Why should I even care about this? Well, because we have these residents who are of this culture. We have nurses and staff who are of this culture. What are you saying to me? Okay, and we can talk more about that too. All right, I'm got the hook. Right? Which
Okay,
if
we
you
have to
don't- if you don't- if you don't know
dismantle
me
our
yet, I
stage here
do
for a
that.
minute, but stay tuned. We'll have our next speaker up.
Thank you so much for your questions.